Thank you, Mike. And what a wonderful discussion. Now, shifting gears to absence of disease, we have talked a lot about presence of disease on the power of zero and the upcoming role of potentially the soft plaque on the contrast enhanced CT. So I think so. Since the introduction of this concept in 2019 about the power of zero concept, it has been called many things: a worthless slogan, blind spot, Pandora box, fallacy, and many others. But again, the appeal of that a simple non-contrast CT scan that's widely available and cheap and effective that can help us identify individuals with no meaningful disease has stood the test of the time. And really, what I would say, the reason why it is so powerful is that it helps clear the uncertainty that lies with risk factors and biomarker approach. And no better paper than shown by Seth Martin that significant amount of individuals who have who have severe dyslipidemia have no plaque. And if you look at outcomes, really, even with severe LDL, individuals have much lower risk than if you have normal LDL and high amount of early amount of plaque buildup. And it's just not about dyslipidemia, but also you can slice and dice the pie however you want across all the risk factors that you consider high. Almost 1/3 of half of them will have a calcium score of zero, and their revised risk is going to be much lower than anticipated. And when you look truly within the setting of the guidelines and how we decide statin, clearly we have shown that it's as good as a coin toss, where half of these individuals may not have any detectable cornea atherosclerosis by the non-contrast CT scan, in whom the risk is much lower than they would be considering for statin. And taking all of this information, finally, the guidelines, and not only national but international guidelines, have adopted the utilization of power of zero in deciding who should be on statin and not. Clearly, what it shows that this is the best tiebreaker if you're uncertain. Before considering statin or other preventive therapy, do a non-contrast CT scan calcium score. And if it's zero, you can have much more flexibility. Now, in this setting, of course, there are parallel advancements that have happened we have seen that with the contrast CT enhanced angiogram, you can see and detect a huge diversity of atherosclerotic disease, high risk plaque features, and especially the non-calcified plaque, and asking us to think if there is life beyond the non-contrast CT scan. And I'm definitely very privileged to be part of this journey and initiating maybe the only population-based cohort in the country that have addressed this issue, the Miami Heart Study. And what we showed that in low-risk individuals, nearly half of these individuals have some form of atherosclerotic disease by CTA. In fact, almost 16% of individuals with a calcium score of zero had exclusive non-calcified plaque. And not only that, but many of our group has shown that in high-risk individuals such as diabetic, severe dyslipidemia, or with genetic dyslipidemia, elevated lipoprotein A, or familial hypercholesterolemia, actually the presence of the plaque is even much higher. So it has led to me to ask the question that whether it's time, let's take a step back. Is it time in the primary prevention setting to shift our gears and move from calcium scan to a CTA? And before I take a leap, I hope that you all will challenge me and ask me to show the money. And ask the hard question. And the first question is, are truly diabetics are at a higher risk with the calcium score of zero? If you ask Matt Budoff and Nathan Wong, the answer will be no, because their data has suggested that the power of zero is as powerful as in type 1 and type 2 diabetics. What about if we take individuals who have genetic dyslipidemia and exposed to elevated lipoprotein A all their life? 40% of them will have a calcium score of zero. In a 13-year follow-up, there is no increased risk. And this extends even to individuals with familial hypercholesterolemia, and these studies had shown that it's not a homogeneous disease. Almost about half of these individuals, even in their middle age with suboptimal lipid control, have a calcium score of 0. And from where you can point me is they're really not an increased risk in this group. But we're talking about CTA versus calcium score, and you can also point me to the fact that even if you treat these individuals with severe hyperlipidemia with PCSK9 and genetic dyslipidemia data from 4 cohorts, actually, you'll need to treat almost 250 to 600 individuals to prevent one event with an expensive therapy. And hence, some of us have argued that in calcium score of 0, maybe it's not the value added. But the discussion is really around CT angiograms, and I'm saying, well, what happens if you would have used CT angiogram instead of a calcium score in an asymptomatic? And you can point out to, before I go there, actually, I just also want to show a study that from the San Francisco study, which was the only study done, a clinical trial in calcium with calcium testing and intervention of a low-dose statin. Actually, if you have a calcium score less than 100, you don't have any events. And what about if you treat a lot of individuals with calcium score of 0 with statins? And the Walter Reed study showed that actually you're not going to make an event even in 12 years of follow-up. But as I said, the discussions around CT angiogram, and in asymptomatic individuals, actually the large confirmed trial with 8,000 individuals without chest pain who got CT angiogram, had 5 to 10% of non-calcified plaque, didn't show any predictive value. And in a smaller study done in Korea showed the same thing. And these findings can also extend to symptomatic individuals, actually, where the Scott Hart study said, if you take into account your calcium scores, whether you have adverse plaque or significant disease doesn't matter in the short term. And this large study on the right from UK that followed individuals with a calcium score of 0 despite positive CTA showed no major adverse event, questioning, and rightly so, is there any value on added CT angiogram in this population? Now, of course, I would like to point out that the Scott Hart's authors suggest that patients with a calcium score of 0 have a good but not perfect prognosis, and CT is going to provide you better stratification. And why do they say that? Because few MIs were missed with calcium score of 0. And how many of them? Actually, 4 out of 41. But if you ask them what happens if you had a normal CT angiogram, are any MIs missed? Actually, 3 out of 41. So I'm not clinical trial, I would say an expert, but if you want to show this is meaningful, and Dr. Marin can help me here, is you may need almost 4,000 individuals in a study to show that a calcium score of 0 versus a normal CTA, there is actually a difference, meaningful difference. So in this background, and the question is, why is that? When we looked into the Miami Heart study clearly, and no pun intended, is that with calcium score of 0, your plaque burden is extremely low, and less than 1% individuals will have any low attenuation plaque that which we are worried about. So now, in this settings, of course, now there are 3 clinical trials that are comparing CT angiogram versus risk factor approach for outcomes, and Dr. Marin is leading one. And I think so we have smartly designed the study because there is no calcium testing in these trials. And if they would have done that, they would have seen that nearly 1 in 2 individuals would have a calcium score of 0. Even if you have a liberal high risk events, wouldn't be more than 1.5 to 2%. Assuming a 30% relative risk reduction, any intervention would need to treat almost 180 individuals minimum to reduce one event. And to show this difference, you may need 15,000 individuals with a calcium score of 0 to make any meaningful difference, if that ever exists. So yes, I'm extremely bullish about CT angiogram, about its ability to give us insights around the biology, as well as possibly changes with interventions. But I would say let's stick to what the experts are saying. And they're suggesting that with a calcium score of 0, the risk is such a low risk group that you don't really need to do anything. Yes, CTA provides you great pictures, but there is literally no value. So my final conclusion is that let's not make exclusively non-calcified plaque the boogeyman. The power of 0 is stronger than the soft plaque. It's time to completely accept it. It is all about meaningful plaque rock hard data is always going to trump the pretty images you're going to get with the CT angiogram. And my final witness in the box is this guy. Anybody knows him? Bruce Brundage, one of the founding fathers of CT angiogram. And this is what he has to say, if I can play it here.
I-ELCAP is so small that we have proven that you don't either chance of having coronary or cardiovascular events is
So I leave my case here. Thank you so much.